My name is Jean Fajadé, and I really the pleasure to chair this session with the work on we will talk about the role of the transradial approach in PCI, from complex PCI to peripheral, and we'll talk about a carotid intervention. So thanks to the support of the Rumo company, it's my pleasure to chair this session with Sasko Kedef, our moderator today, and discussant Adèle Amignan, Benjamin Rantong, and Marco Roffi. Our chat master today will be Thomas Ovas. So the learning objective of this session is to demonstrate how to optimize challenging coronary and peripheral cases using dedicated device via transradial access. The second is to appreciate the value of transradial approach for complex PCI and carotid stenting, and we will have two recorded cases on the left main bifurcation for coronary, and a very nice case on carotid stenting. And finally, with Marco Roffi, to acknowledge the Ultimaster DES result in high bleeding risk patient population. So, Sasko, you can moderate and stimulate the discussion.
Yes, thank you very much, John. And we appreciate very much your presence today, and we will share with you this great celebration of 30 years of Radial in real-world practice. I would like, from the very beginning, to encourage you to take active participation and do not hesitate to ask any questions. We'll have our chat master on site. It is Thomas today, and he will try to answer some of the questions, and maybe we will address most of the valuable, important questions on site.
Okay, thank you, Sasko. And now we move to the history of transradial access, because this year.
So this year, Dr. Fajadé, we are celebrating the 30 years of transradial intervention. It's a long journey. You know that everybody knows that now transradial access is the first line recommended vascular access in coronary angiography intervention, supported by European and US guidelines. It has been a long journey to get to this endorsement. You, Dr. Fajadé, you were one of the pioneers to start using this approach. So my first very interesting question is, please tell us about your journey. How did you come up to even consider going from femoral to radial? We will be very interested to know your story and why did you went to this access.
Oh, thank you for the question. So I will be short. I know that we have time to respect, but I could tell you the story for 1 or 2 hours. It's to be short. It was 30 years ago, and I was in the ACC meeting and listening to different sessions, and all the time AHA or ACC meeting, I spent a lot of time to see the poster. And I was working in the poster area, and suddenly I stopped. In front of the poster, it was the first, I think, 25 case via transradial access, and presented by Ferdinand Quimenet. I never saw this guy before. We have quite the same age, so at that time we were quite young. And immediately I connect with him. I said, what this? Radial is there, and we use this route because the main point was to reduce the bleeding complication. And we have to know that at that time, it was the beginning of the stent. We have a very aggressive anticoagulation therapy. The rate of bleeding complication was very high. Around 3–4% of the patient went to surgery at that time. There was around 15–20% bleeding, complication, hematoma. So it was really, we are thinking at that time on the closure device, etc. This was the beginning of the per-close, etc. And so he told me, look, palpate your radial. So I did it in front of him. Look at it. It just, you could feel it. And if you press on your radial, he told me you compress your radial on the bone and you stop immediately the bleeding. And it's true that the demonstration was easy, really understandable. And I say it's fantastic. So we look at the poster explaining everything. No bleeding complication on the first 25 patients. And we exchange during close to 1 hour in front of the poster. And when I left him, I said to Ferdinand, immediately when I come to Toulouse, my first objective will be to come to see you in a OLVG hospital in Amsterdam to see the cases. And so when I came back to Toulouse, I said to my master, Jean-Marco, I saw everything. How was the SEC? I say, studies, what you want, but one thing, radial access. The rest is really not important, but this is really unbelievable. And so 2 weeks later, I took the plane from Toulouse to Amsterdam. I spent 3–4 days in the cath lab with Ferdinand Quimenet. And we did together. It was really nice because I was with him at the table doing the puncture, etc. So he trained me during 4 days. And then I come back to Toulouse and we start immediately. The problem was the material. Yeah. So we need a special needle at that time. It was not 6 French, it was 7 French sheath, 7 French guiding catheter, etc. And so we did with Jean-Marco 6–7 cases each. And the week after, we had the live transmission to the TCT. And I called Martin Léon, and of course Ferdinand Quimenet. If you agree, we have they proposed to us to perform 2 cases. We can perform the first live case in the world via transradial access. And so I called Ferdinand, I remember it was 20 minutes before taking the line, and I told him we are ready, we have the patient on the table, they are really big radial, so normally the puncture will be okay, etc. And he told me, if you are success, if it is a success, it will be fantastic for me, the radial, etc. If you fail the 2 cases, it should be the end of the story. And fortunately, the 2 cases went well, and that was the beginning of the radial access history. Yeah.
It's an amazing story. So you have learned from a colleague, and you have built your own experience at the very beginning of this technique, and now it seems just not believable not to use this access because of its safety profile and so on. So if that meeting at that time was remote, you will not start radial access. I'm joking. No.
It could be, yeah.
So it's a great story. Thank you so much. I mean, it's a great evolution. I mean, you had to struggle that time to prove that it was a good concept. I mean, sure. There was a lot of resistance among femoralists and so on. So it was a long journey to come up to that great recommendation from the guidelines.
To be honest, and we can say this because you can close the door, but nobody will listening what I say outside. You cannot imagine
the resistance. What we faced.
Take in the face all the people
who
think they are crazy guys, this is a stupid way, etc., etc., etc. We have listened a lot of
or it's just another
nice
access.
comments.
It's just another access.
That's life.
That's what people said. So
okay.
Thank you so much for Dr. Fajade. I would like now to give my second interview. So we know that transradial access now is used as the first line access for coronary procedures, but there are a lot of non-coronary procedures now using the radial access, peripheral intervention, neuro intervention, a lot of other fields are using this access for its safety profile. We have here the privilege to have Dr. Sasko Kedef, who is probably one of the most experienced operators using the radial access for peripheral. Peripheral is more challenging because you need dedicated devices, you need a longer sheet, you need longer catheters, and etc. So Could you tell us a little bit more again about how you come up also to use this access for peripheral, and what change what kind of innovation allowed you to move forward in this field at the level that you are now, actually?
Yeah, it was somewhere 2006, I think. At that time, we were more than 90% of radial for coronary procedure, diagnostic and interventions. And Clinique Pasteur from Toulouse and Jean's experience were great motivation for us at that time. Jean was presenting more than tens of thousands radial procedure from his practice on a great meeting. So it was very motivational. And at that time, I personally increased my carotid volume, and I dedicated myself to do more than 90% from the very beginning. It was not easy. It was kind of very difficult because carotids can be very challenging in access. But, you know, walk-in, walk-out benefit is great benefit. Radial is allowing us, not just for a coronary procedure. Particularly in peripherals, we know that access site complications are still the most frequent complications. And not just that, but bleeding as well is most significant complications, even in peripherals. For carotids, furthermore, complex aortic arch is very difficult in some cases from femoral, whereas in a radial, it allows you very natural, straightforward access. So it is much easier to do right carotid procedures, bovine left, which is particularly challenging from a femoral access, very elegantly and shortly from a radial. And what is very important, you are not aggressive to the aortic wall. So in doing a right carotid, you're not touching aorta. So you do not have to puncture directly carotid to avoid the aortic arch. So you go radial. Furthermore, we extended experience for iliacs, because we had enough length of the catheters, following by some SFA procedures. To be honest, are not so easy nowadays still, because we are lacking a wide variety of devices with enough length. I think in future we'll have this, because we are addressing this to the industry and expect this solution.
Okay, great. We will have a case of peripheral intervention, so we will really listen to your experience regarding how to tackle these cases. So thank you so much, and congratulations for all you and Dr. Fajade, for all you have brought to the community with the Transradial access. Thank you.
So we can start now and move to the recorded case, the coronary case. If we can have it on the slide, okay.
Welcome to Clinique Pasteur for this TNT session sponsored by Terumo. The topic of today is the treatment of a patient with a multivessel disease by the transradial approach. And I have the great pleasure to perform this case with my partner, Dr. Nicolas Dumonteil. So maybe I can now present the case. It's a quite young patient, 63 years old. He is a smoker and is treated for high blood pressure. His normal life. He has a previous episode of paroxysmal atrial fibrillation and developed recently some de novo angina class 2. So on the lab investigation, there is no abnormality. The ECG is normal, and he has a thallium scintigraphy that demonstrates some quite large ischemia on the anterior and inferior wall, with a small reduction of the ejection fraction during exertion. Ejection fraction is normal at rest. So for the baseline angiography, this is the EP view. You can see on this first view quite tight lesion at the level of the distal left main. It's not much calcified, and there is also a tight lesion on the first marginal. Then we will move on the cranial view. The cranial view confirms this lesion, this tight lesion of the distal left main. This is quite like a spider view, but maybe less caudal, less LAO, sorry. And we confirm perfectly here the tight lesion at the level of the distal left main. It's not recalcified, some involvement of the ostium of the circumflex, and also the tight lesion of the first marginal. Finally, this is a patient with multivessel disease, and he has also a chronic total occlusion at the level of the mid-RCA. We can see that it's a quite short chronic total occlusion, and we can see also that probably there is a small connection just at the distality of the CTO. We confirm on this aerial view the length of the occlusion, and also we can see maybe better, yeah, you see here, the small connection at the level of the distality of the CTO, but it's a quite straight segment. So to see the risk evaluation, the Euro score is quite low, he has no major problem. The angiographic syntax score is 21, so it's quite low. And when we compare the syntax score 2, this is in favor maybe of PCI compared to CABG. We can see that it's equality, but this patient could be treated if needed by PCI. So what is the key clinical data to summarize this case? 63 years old male patient, non-diabetic. He is under NOAC for paroxysmal atrial fibrillation. He has a multivessel disease with a distal left main and CTO of the right coronary artery, normal LV function, and low syntax score. So the goal of today is the management of the multivessel disease patient via the Transradial approach. Our strategy was to do this in a staged fashion. We try first to reopen the right, the CTO of the right as a first step. Then as a second step, we will treat the distal left main and the first marginal. And we anticipate to perform a provisional strategy for the distal left main. So maybe we can show you the procedure of the right. This is done by the left transradial approach because the right radial is quite small and it's not achievable to perform the procedure by this way. So we use an Amplatz 0.75, and we were able to cross the CTO using the fine cross, the microcatheter fine cross, and the Fielder XT. And here you can see on the right the injection of through the microcatheter. And this is the final result after predilatation and implantation of two drug-eluting sets, Ultimaster side. It was a 3-0 by 38 and then 3-0 by 18, and you can see a very nice result. This was done 1 week ago. And so the topic of today is to do the left main and the first marginal, and Nicolas. Yep. This will be done by left transradial approach. As I said before, this patient has a remnant right radial artery, and there was a failure even to advance a 4 French diagnostic catheter. We'll use a 6 French extra backup 3.5. We will do wiring of the LAD and the first marginal, then stenting of the first marginal because it's a quite distal lesion, then stenting of the distal left main using POT, and then evaluation of the circumflex, probably a kissing, and then see if needed to use an additional stent using the TAP technique. Okay, this is the strategy, and maybe now we can move to perform the case. So, Nicolas, you perform the puncture.
Yes. I think we can
so
stop.
We will now control the result at the level of the first marginal after.
So we went.
And Sasko, if you have any comment on the case presentation, the way to perform, it was a left radial in this particular case.
Yes, success site is particularly important in this case because they did 2 previous procedures before this target left main PCI. So first they try right radial, and there was a small radial. It was a remnant radial. In this situation, we strongly recommended doing radial angiography because if you have a road map or if you do ultrasound, then you will know whether you can proceed or not. So in this case, with angiography, we will also be able to appreciate what is the size of ulnar, right ipsilateral ulnar artery, because in this particular case, the third intervention could be performed from an ulnar artery, which is in most cases of a right remnant small radial artery, pretty decent size of artery. But it is a perfectly viable option, as they are doing, to go from a left radial side. Maybe I could ask one of the world experts of a distal radial access whether you will consider left distal in this particular case, because it is much more ergonomic. And so.
But just before, if you have any question, do not hesitate. You can stand up, use the microphone here, or you can send question on the chat and we will answer to you immediately. Do not hesitate. We are here for sharing. Go on.
Thank you, Prof.
Thanks.
Just wanted to ask, if the radial is very small, should we not avoid the ulnar for safety of the patient's hand?
Safety is not in question at all, because there is not just radial and ulnar arteries which are important for hand circulation. There are anterior interosseous artery, posterior interosseous artery, and a huge collateration circulation, arterial circulation in the forearm. So hand ischemia is not an issue.
But that's it. Thank you for the question, because it's an important point. In other words, during 25 years or 20 years, we did the Allen test in order to be sure that we could do the radial or not. Then the Allen test, which was manually compression of ulnar and radial, was replaced by, the oximeter, etc. But today we realize, and Sasko is right, that in fact you could lose your artery, nothing particular is happening. Because, what he said, there are a lot of other vessels.
I mean, yes,
comment on that?
Yeah, the question was very important. Are you afraid if you have a fear of the radial? It's a small one. Is it dangerous? And you have answered the question. To go to the ulnar, you have answered nicely the question because of the extensive anastomotic network, which is all something very that we cannot we underestimate a little bit that. But one of the important points here is that some people, when they fail the radial, they move directly to femoral. This is a strong message here also, that keep up with the wrist axis and try different axes. You can go to the left, you can go to ulnar. Of course, you have a big experience with ulnar, and we have had this discussion with Nicolas Dumontoy that an inexperienced operator can use ultrasound to increase their success rate of accessing the ulnar, because it's more difficult actually to puncture the ulnar than the radial. Of course, if you go to the left, the distal is a good option if you have experience with this access. It's more ergonomic. You can place the hand of the patient in a better position. It's very elegant. So it's also a good option to keep in mind. Also, sometimes some people that failed radial, they go to ipsilateral distal and they succeed. So there is something, sometimes you can create spasm. And so there are many options. The message is don't go too fast to the femoral, because some people, okay, they cannot go radial, so they go directly to femoral. This is a little bit, a pity. So.
Yeah, and this patient is, just to remind you, high bleeding risk patient.
Yeah.
So we have to practice a femoral avoidance strategy in this particular case.
And also, I like very much the workflow of this patient. You know, the equipoise between the syntax 2 score between the two. Between surgery and PCI, the way, and if you have to go for PCI, then you need to go for a complete revascularization. So they start first with the right, because if you cannot open the right, then maybe you have to reconsider surgery. So I like very much, it's a very modern workflow that they propose here. Beyond the access, I like very much the way that they are handling this case. It's very nice.
Okay, we can move on if you agree on the case.
For post-dilatation, we have 3.0 NC. And let's have a look now.
It's nice, huh?
Yeah, it's nice. Graphically, it's better. Okay, so let's go now to our left main lesion. So
the strategy. Can you resume the strategy?
Yeah, it's a provisional stenting strategy according to the repartition of the atheroma to the lesion. And also to the angulation of the circ and the LAD. So, of course, as you mentioned, we'll pre-dilate. Je prends un 3.5.
So pre-dilatation, then stenting left main
towards LAD. Stented, the stent, of course, chosen according to the diameter of proximal LAD. And, of course, POTS to optimize its apposition in the left main. Kissing. After recrossing the struts from the left main LAD towards the circ, final POTS, and then we'll assess our outcome and decide whether it is satisfactory, especially regarding the ostium of circumflex. And if it's not, I think the angulation and the configuration of circumflex makes the choice of a tap, as you detailed them, Bruno, makes the choice of a tap the best suited for such patient and such anatomy.
But to be honest, a culotte also could be could be done. I think that you like culotte technique, and culotte here you have quite two large vessels. The fact that with the tap you have a quite open angulation that allows to perform a tap.
Exactly. Okay, Bruno. So the pre-dilatation of the left main was good. Now comes the choice of a stent, diameter and length. So have a look at the 3.5 balloon and at the angio control that we made. We clearly see that the proximal LAD is bigger than 3.5.
Yeah, so I think a cut 4.0 is a good choice. Huh?
Yeah, 4.0 regarding diameter, and here it was 15 millimeter of length.
Yeah.
And we want to cover all the left main and to land in the proximal LAD. So we need to be a little bit longer than that.
So 18 should be maybe too short. So 21 is a good length. I think
you will have a good length and a safety margin with a 21. Okay.
So it's a 4.0 by 21 millimeter Ultimaster size stent.
Okay. Yeah, it's better here.
Yeah.
Okay.
Maybe we can just confirm that we cover the proximal LAD, but I think so. Huh? Here,
yeah.
Okay.
It's good. So let's inflate here.
Okay.
Okay, to the nominal pressure.
12 atmosphere, no more.
Yeah. So you see expansion is good. Hemodynamic tolerance is good. Recording that.
You can deflate and just pull back a little bit. Huh? What do you see? Can go to higher pressure.
Okay. Exactly. So I'm just waiting for the balloon to deflate. Backing it a little bit my guiding catheter.
Yeah, okay.
And now you can go to a higher pressure, Bruno. Okay.
So we do like a first pot.
It's a kind of a pre-pot.
Pre-pot.
With
4.0 inflated at 20 atmosphere.
Good. And again, let's wait for the balloon to deflate.
Yeah. And we have to remove it quite gently in order to avoid any deep intubation and crushing of the proximal part.
Exactly. It's at that step that you can create some longitudinal compression if you are pulling too much or too quick on the balloon before it's fully deflated. Okay, so let's do the pot here, Bruno.
Yeah, maybe a small.
You want a small angio?
Just to control that the circumflex is still open.
Exactly. So let's do a pot. We have a 4.0 LAD, a 3.0 surge.
So normally 5.0 should be okay.
I think so. Yeah.
So the position of the balloon.
Yeah, let's make a small test, but we have to put the distal tip of the balloon at the carena.
Yeah, I think it's
here. It's good. I think.
Maybe,
okay.
Okay.
And what pressure are you
16.
Going? 16. Okay.
And probably we can just pull back now a little bit.
Yeah.
To step for the pot to be sure that all the stent's length is well open.
And here I think it's good. Okay. And here you're going to 20. Let's record that. Good.
Okay.
So interesting. We see some carena and plaque shift towards the.
Okay, I think we can make a stop here and have a discussion, Sasco, with your colleague. Do not hesitate again. If you have any question on the why to use this kind of balloon, the size, the way to perform, we are here for you. And do not hesitate. You can stand up and take the microphone. Sasco.
Yeah, it seems like a perfect provisional strategy. So it's one of the landmark of this PCR left main procedures we were taught by Jean and his team for a long time, and we have a strong evidence that this is probably the best strategy to start with a type of left main lesion like this.
I have a comment. So obviously in Toulouse they are master in performing left main stenting with a 6 French approach. We like to do it in 7 French, and people who like to do that in 7 French should not be afraid with respect to access, because a 7 French access may be using a mother-in-child technique with the Judkins 5 French, 125 centimeter long. You can really perform a procedure with 7 French guiding catheter from a radial approach in the vast majority of patients.
So just for the technique, you can leave the last angiography, the last image on the screen, okay, when we are discussing. Thank you.
Yes, I agree with Marco that I know that Toulouse, they masterize the technique with 6 French. I also sometimes use 7 French for the left main for device compatibility, but also because it's more comfortable when you have to inflate very large balloons. Sometimes it's less bulky. So if the radial artery of the patient can tolerate a 7 French, especially the slender, I think it's a good option. I know that in Toulouse they are very good. I mean, they put a 4 French. They do nicely the pot. It looks angiographically it looks already great, and you have to do some work on the circumflex, of course. Do you think that it's still important, I mean, do you do an IVUS, for example, on your left main, Dr. Fajade, or do you think that angio is enough? Or because we can be surprised sometimes, even if you use large balloon, that even sometimes you're a little bit under the real size of the left main. You can have very large left main, I mean, sometimes up to 6 millimeters. So do you think here, for example, when you look at this result already on the left main with a nice, perfect done pot with a 5 millimeter balloon, which is one of the largest one, do you think that still it's important to assess the apposition with IVUS or not?
No, I think that it depends. Of course, if you want to be really precise, you can use systematically intracoronary imaging, IVUS, also CT, to see exactly the diameter, the apposition of the stent, etc. But there is one, rule which is working all the time, very simple. You take the sum of the 2 diameters, LAD and circumflex. So here is around 3.5, 3.5. The sum is 7. You take 2/3 of that, and you have close the diameter of your left main. So the 2/3 of the sum of diameter, I can tell you this is working. If you want to be precise, you take intracoronary imaging. So here we are at 5 millimeter. Maybe on the distality of the left main, it could be a little bit over-dilated. But the problem now, what to do with this circumflex? Just balloon?
So
stenting?
It's a
double stent?
Ostial lesion, so it's not extending a lot. I expect a good result after pot side pot or kissing, and then you have to assess what is the residual stenosis at the level of the ostium. If it's acceptable, I will leave it like this for sure. This is the goal of the provisional. And if you have something that you are not happy with, then you do a tap, which is probably the best technique. And here we have a nice angulation for the tap. I mean, it's a very almost 90 degrees, so you will not expect a lot of protrusion of the stent into the left main. So this is a perfect case for a tap. This is perfect for a tap.
Okay.
It's very, very important to see what will be the result after recrossing, most probably through the most possibly distal stent strut, in order to move some of the stents away from the carina and see what will be angiographic result after a circumflex dilatation.
Okay. So we move to the case.
Maybe just one more comment is that
yes.
In the entire, let's say, strategy here, we have to think also on the bleeding perspective, antithrombotic perspective. So we have a patient here that is a high bleeding risk per definition because he will need a prolonged oral anticoagulation. He was treated with the appropriate stent. We will see later because we have strong data for the stent in reducing the duration of dual antiplatelet therapy. Nevertheless, he has already 2 stents, 2 long stents in the right coronary artery. He has a left main stent. So if we can stay away from a 2-stent technique in the left main because of this perspective of antithrombosis, it may be a good thing.
That's a very good point. I remember that this patient had atrial fibrillation, is under anticoagulation therapy, so, and we will discuss this a little bit later, but it's a very good point. In other words, we have to anticipate this when you are doing the procedure in order to try to avoid multiple stenting in this kind of patient.
Yeah.
for sure it's something what we need to correct, at least by kissing balloon inflation.
Yeah, agreed.
And we'll see after kissing balloon inflation whether it's enough or not. Yeah. So here to recross, je vais prendre le troisième guide. Here to recross, you have two options. Either you use your LED wire and you recross toward the circumflex, but in case you have any issue, you can lose your true lumen entering the left main towards the LED. So the other option that I like and that I'm currently using is to use a third wire. That way I do not remove my LED wire that is in the right place since the beginning of the procedure. And I'm just going to advance my third wire. First step will be to be sure that I'm entering the left main stent coaxially. So usually you ensure that your guiding catheter is en face, and you go towards the LED, that is the case here, and then you try to wire the struts of the stent. Ideally, maybe, Bruno, the more distal one. Yeah. So I'm zooming in a little bit, and maybe you can make a small test for me. Okay, and usually the pot helps you
Very nice
to cross and to go towards the struts. So now I have my wire, one wire in the true lumen going to the LED, the other one in the true lumen going to the circ. And what I have to do is to remove my gelled wire in the circumflex. So again, we did the pot, but I want to avoid any longitudinal compression. So I'm pulling a little bit on my guiding catheter in order to avoid to compress my stent by unjailing my circumflex wire.
Very nice.
That's a very important point. In other words, when we have to remove the jail wire, you have to first to disengage the guiding at least 1 centimeter, and then you can remove the jail wire, because all the time the guiding, we try to intubate again, in order to avoid the longitudinal compression.
I think that we use a 4-0 for the LED, so 4-0 non-compliant short balloon for the LED, and a 3-0 for the circumflex.
And here is the LED one. So
12.
Yeah, I'm at 12, 14 also. Let's record that. Okay, and let's deflate.
Okay.
And important, Bruno, not to inflate at a too low pressure of the balloon here, especially the LED one. Huh? So let's control now what we have.
But we don't need to go to very high pressure because we already do a pot at this level. So
exactly.
Normally the stent of the LED is perfect.
Okay.
So now it's time to see what's the result after the kissing in order to evaluate the circumflex.
It's not so bad.
No, I think it's correct. Huh?
Yeah, because we don't have significant more than 50% residual lesion on the ostial circ. What we see, and maybe we can mag a little bit and record without injection, is that we have a good scaffolding on the circumflex, provided by the crossing at the distal part. Okay. Let's record that.
Yes, we see the opening here. Yeah, that's nice.
I think maybe we need to go to the spider view.
Spider view,
to better control the ostial of the circumflex, to make our final decision on whether to stent it or not.
Okay. So this is the control in the spider view.
Okay.
No, for me it's good. Huh?
Yeah, for me also in the circumflex.
No major dissection.
No.
And quite nice angiographic results, less than 50% and less than 30% residual stenosis.
Yeah.
I would say I will be very happy.
Yeah.
So probably what we can do as a next step is to do a final pot.
A final pot,
yeah. With a 5-0, just for
I think so.
14. So here maybe you can re-advance your guiding with the protection of the balloon inside the left main, so like this. So you will not damage the stent because the stent is protected by the balloon.
You use it to enter the left main stent. Okay, wires are a little bit wrapped up.
C'est bon.
Okay. So let's Bruno. Let's do our
Final
angiography.
Okay.
In that view,
Yeah, first in that view, yeah.
Yeah, that was close to the one we used initially.
It's correct, huh?
Yeah, I think so. And let's go maybe to the cranial one.
Yeah, maybe some nitrates to control the result. No,
Okay.
the LED is okay, and we don't see the section beyond the distal to the stent.
Exactly.
So now we have
and on the mid portion, and it's always
stable.
And
Maybe we can remove the wire and do the final angio.
Yeah.
Very nice result at the level of the left main.
Yeah.
Proximal LED, the stent is perfect. And the ostium of circumflex, there is some radial stenosis, but I think it's less than 50%.
I think so.
And without any evident dissection. So I think we can accept and tolerate this result.
And
we can move to the
spider.
Spider view. That's important to have a second view to confirm the result of the circumflex. Oh, it's nice, huh?
No, it's nice.
It's nice.
Okay, Bruno, we finished that case. Maybe you can summarize the main learnings that we had during that.
Yes, Nicolas, it was the topic today is to demonstrate always that we can treat multivessel disease patient using the transradial approach. And in fact, it was the case for this particular patient. We do first the CTO of the right, and second, a complex distal left main and marginal branch lesion. So I think that we can confirm that we can perform all the PCI procedure using the transradial approach, even complex one like a CTO or a distal left main.
Thank you, Bruno.
Thank you.
And thank you to our team for their support during that case.
And thank you also for Terimo to have be able to make this session possible.
Okay. Bye.
Bye. So we will now control the result at the level of the first margin.
Okay, so I think it was an interesting case, provisional stenting strategy. I would like to really thank my former partner, Bruno Farah and Nicolas de Monte, and for this great case. Any comment on the way to perform, the result?
The last zoomed image was very impressive, where we can clearly see some stent struts moved away from carina toward the side of a left circumflex. I mean, so it looks perfectly fine for me. No need for additional stent, at least I think in this case.
It was really a fantastic and teaching case. So easy from Transradial, good strategy. Using the Finello pot side, the pot which is just based, as you said, on the angiography, assessment of the side branch, the rewiring, the cranial projection to be sure that you are not missing the ostium. Everything was here. It was just a teaching case. It was perfect. So I'd just like to ask the audience, who would consider going femoral in this case? Who would go femoral in the audience for such a case, for left main? Okay, no one. No one. So everybody do
radial? Everybody will agree for the radial access?
Okay, perfect.
A lot. Yeah.
A lot.
So they are in the other session, the femoralists.
And just a question for me: who would consider at the end pot side pot instead of kissing? Oh, okay. Not a lot.
I think it was good
but
teaching point.
That's important. You could discuss that.
Yeah, it's a very, very good point to
pot
touch upon.
side
Because,
pot,
because
and not
after
kissing, and vice versa.
After kissing,
and what is the difference?
Yeah, after kissing balloon inflation, we have some degree of oval distortion of a proximal stent in most cases. So two balloons never dilate the proximal stent uniformly. So we need to correct this oval distortion with a last pot inflation.
Which actually is placed a little bit more proximal, because you have already done the job at the level of the carina. So the only thing that you want to correct is the proximal part. Yeah.
Question from our friend.
Just a small comment, Dr. John. We discussed many years back also. In this case, we had a carina shift towards the circumflex. We have an option of distal cell or proximal cell when the circumflex ostium looks absolutely normal after crossover stenting. But when it is pinched, I do not think that we have an option of distal or proximal cell. The wire will take the cell in front of the pinched ostium of the circumflex. So we do not have an option of crossing distally or proximally because it is just open. Only one cell is in front of that pinched circumflex and the wire will go there only. So probably it's not possible for us to decide proximal or distal when it is tightly pinched like in this case. There is only one cell probably from which the wire will go.
Tashko, you want to?
Yeah, I think that's a good point, but in this particular case, when you do not have a significant ostial circumflex, it is not so difficult to cross as distal as possible. But sometimes, if it is very tight lesion, you can predilate first whenever you cross, and then try to re-enter with additional wire. Because you will have your first wire in place, and it will be like a roadmap for your second wire.
Yeah, that is where when the circumflex ostium is absolutely normal, we can cross from multiple cells and then we can decide the distal most. But if the ostium is very tight, then generally there is just one cell where the wire goes.
Yeah, but then you predilate and then you reconsider re-entering with additional wire. Yes,
okay. Okay.
And Jean, there is a very important question I think we should address. Yeah. The question is why, who would do left main PCI without IVUS? We should ask this question. Who will stay like this and do this left main procedure without IVUS? Okay, and who will strongly support using IVUS in this case? I think less people support this. Maybe, Jean, can you tell your personal experience? More than a few decades of left main PCI.
What I would say, it's really difficult to try to convince the people today. In other words, I have performed with Bruno Farah, all the team, a lot of left main PCI without intravascular imaging and trying to achieve the best angiographic result as possible. So it's true that IVUS can give you the confirmation or not of the quality of your procedure, but on the other way, I am sure, and I'm still sure, that you can do without intracoronary imaging achieve good result on the different procedure, particularly left main. But you need to be really strict with the basics of coronary angioplasty. In other words, you saw in this video the quality of the angiography, the quality of the views where they are working. Second, at the end they finish with the 5 millimeter balloon. So if you place IVUS and if we have what to do more. You have to integrate what we have learned in the past without IVUS and try to continue what we feel which is the right way to do. Second, and this is again, the door are closed, there is something for me shocking. When you see some key opinion leaders showing IVUS must be done, etc., in all the procedure in order to get the best angiographic result, and in their cath lab, they are not doing this in routine practice, for me, this is unacceptable. So, it's like that. Again, with my age, I can say that, and if it's shocking, maybe next year I will not be here. But really, it's impossible. First, financially, Benjamin Gontong is here. In Toulouse, if tomorrow or next week, Benjamin Gontong with Bruno Farah, Nicolas Dumontet, I started to use intracoronary imaging for all the procedures, coronary procedure, I can tell you, after 3 days, the director of the hospital will say, okay, we stop. You have to make a choice. You can do this outside, but not in Clinique Pasteur. This is the reality. So you have, on one hand, all the data, the p-value, etc., and we can discuss this, the validity of the p-value, and on the other hand, we need to work in daily practice. And I prefer to treat 1,000 patients with bifurcation, with a good angiographic result with Altivus, better than 50 with Altivus, and the rest of the patient you don't care. We are here to treat patients. We are here to try to, improve the clinical outcome of the patient, try to reduce the mortality, try to improve the daily physical exercise, etc. But again, in the same time, we have to respect the financial environment, and we are not Minister of Health, Minister of Financial, etc. We have to adapt our way of working to the environment. But this is reality.
Also come from the system where finance is a major issue. Now, I think the utilization of this is coming more when we are thinking calcified lesion, not like this case. And again, if I have a calcified lesion, angiographically, the old age we have done, rota wherever is required, high pressure balloon dilatation. Now we have also this plaque modification balloon. No, I think in continuation of your statement, probably the overutilization is probably to support these devices or what, I don't know. So this is also an important thing. Ultimately, it is the patient which will cost. That session we attended, ultra low contrast PCI, a patient who will require a dialysis in future. Now, if he ends all his money for intervention, what is the future? So I think we'll be more need to be accurate on this late-main intervention. But the Achilles heel till is that LCX ostium. That's my feeling.
No, I agree. It's a good comment. It's the point we talk about ultra contrast PCI. I was following 2 days ago the session driven by Javier Scanet. It was a fantastic demonstration to do a patient with free vessel disease and 25 cc of contrast at the end of the procedure. I think this is something that we have to keep in mind and try to, in the future, to reduce the dose of contrast. Now, thank you for the comment. So yes. I think we need, the time is running. We need to move on the second part of the session, the carotid stenting. But before, we will have to do the transition between the two cases. We will talk about a patient with high bleeding risks. It was a case of this patient with left main stenosis, and it's my pleasure to introduce Marco Roffi, who will talk about treatment for high bleeding risk patients. Marco.
Thank you, Jean. And actually, the case just presented really introduced very nicely the topic. So, and the topic today is really in 5 minutes or less to give you the key learnings from the Master DIPT study. So the Master DIPT is a study, had quite a complex design from, made by Marco Valgimigli. I want to spend some time on these slides. Namely because the patients were all high bleeding risk patients. They were all treated with the Ultimaster stent from Terumo, and there was no really exclusion criteria other than having this stent. Excluded were only patients with a previous stent thrombosis or patients with the in-stent restenosis. So all the patients were treated accordingly to the investigators in terms of antithrombotic treatment up to 30 days. And the patients were randomized at 30 days if they had no clinical ischemic or bleeding events. So you see also the difficulty of the study is because we had to randomize patients at 30 days. It's always easier to randomize and include patients on the table or at the time of index PCI than 30 days. So we had to see all the patients again and encouraging them to participate in the study. So all patients were treated with the Ultimaster stent. All patients were on standard antithrombotic treatment with no ischemic and bleeding complication, and they were then randomized to 2 different antithrombotic regimens. So the abbreviated DAPT, meaning there was an immediate discontinuation of DAPT, or standard DAPT. So the abbreviated DAPT, again, immediate discontinuation of the dual antiplatelet therapy, and this was followed by single antiplatelet agent, open to the investigator, whether aspirin or clopidogrel or ticagrelor or prasugrel, up to 11 months. Or single antiplatelet agent for 5 more months if there were oral anticoagulation, followed by anticoagulation alone. The standard DAPT arm was dual antiplatelet therapy for more than 2 months if they were on oral anticoagulation, or more than 5 months if they were not on oral anticoagulation. So for those who do not well understand, the Ultimaster stent is a cobalt chromium 80 micron strut thickness abluminal resorbable polymer and is a sirolimus eluting stent. So the study had 3 primary endpoints. If the first 2 were met, then the third would come to play. First, 2 non-inferiority endpoints. The first was NACE, all-cause death, MI, stroke, and major bleeding, BARC 3 to 5, on the left side. And you see that the abbreviated regimen was clearly non-inferior to the standard regimen. The second endpoint, really an ischemic endpoint, MACE, all-cause death, MI, or stroke, abbreviated regimen being non-inferior to the standard regimen. At this point, the superiority for bleeding could be tested according to the study design, and you see the abbreviated DAPT was clearly superior as compared with the standard DAPT in terms of BARC 2, 3, or 5 bleeding. Importantly, half of the patients had acute coronary syndromes, and in the antiplatelet treatment in the abbreviated DAPT arm, approximately 30% were on aspirin and 70% on P2Y12 inhibitors, mainly clopidogrel. So importantly, pre-specified analysis on patients on oral anticoagulation, almost 1,700 patients randomized were on oral anticoagulation. And again, the abbreviated arm showed no difference in MACE and less bleeding. So these are already my conclusion, is that stopping DAPT at 1 month was associated with lower bleeding risk without additional ischemic risk in patients with or without oral anticoagulation. So the key findings is that the master DAPT with more than 4,500 patients randomized is by far the largest randomized controlled trials on DAPT duration in high bleeding risk patients. In the study, there were minimal exclusion criteria and a large proportion of patients had ACS. So the result may be widely applicable in clinical practice. Again, the benefit was irrespective of the need of oral anticoagulation. Therefore, in high bleeding risk receiving Ultimaster stent and not experiences ischemic or bleeding events at 1 month, stopping the DAPT should be considered the default strategy. And I thank you for your attention.
That was great, Marco. So can we apply this strategy for our particular live case patient? Because he's on oral anticoagulation, so we can recommend only 1 month of dual antiplatelet.
Clearly, this patient qualified for it, and so the right stent was chosen, and he could be qualified for this strategy.
Okay.
Yes.
Very good point. Thank you very much.
Marco, in this case, would you, after 1 month, would you keep aspirin or clopidogrel?
I would personally keep clopidogrel.
Okay, because most of the patients in the single group were on clopidogrel.
Yes,
also.
clearly.
Yeah. Okay, so we can move now to the second live case.
So now we move to the carotid stenting. Benjamin, you can join us, of course. So we introduce Benjamin Antong, working with Antoine Sauguet in Clinique Pasteur, Toulouse, and taking care of all the peripheral activities, and particularly the carotid stenting.
Thank you, Jean. I'm glad to be here with you, and for two reasons. First of all, Jean, I promise you not to crash financially the clinic buster with IVUS. And second, to share with you this case of 80-year-old man, which is referred to our Center for a tight right internal carotid stenosis suspicion. And you can see that he's suffering from hypertension, diabetes, dyslipidemia, atrial fibrillation, and his medical history started in March 2022 with slight memory disorder conducting his GP to a brain CT scan, and they discover a dateless left frontotemporal lacunar stroke. So in this view, he underwent a carotid Doppler ultrasound and find a 50% left internal carotid stenosis, and the other part, a 90% right internal carotid stenosis. Secondly, after you have this diagnostic, you underwent an angio-CT scan, and this CT scan confirmed a stenosis, but 75% on the right internal carotid. So there is discrepancy between the Doppler ultrasound and the angio. So there is another point important. He has some typical angina pectoris at the presentation, a sharp murmur on the right carotid artery, no abnormality on the lab test, and a treatment which is adapted to his pathology. And you can see on the EKG that there is atrial fibrillation, but also the important trouble of revascularization in the anterior wall. And the transthoracic echography confirmed that there is an endocardiac disease with an impaired left ejection fraction, a diffuse hypokinesia, and no valvular disease in this patient. So I share with you the CT scan, and you can see on the right carotid internal artery this stenosis. It is a left carotid with a 50% Doppler ultrasound stenosis, but on the right, the measurement on the angio-CT give us a 75% stenosis in the nascent. So there is definitely a discordance between the Doppler ultrasound and the CT scan. So and you can see there the reconstruction in the 3D, and which is important for our discussion later, is a type 2 aortic arch. Type 2 means that you have the origin of the brachioatrial trunk, which is below the top of the cross of the aortic arch. This is important. But also you have some calcification, importance of calcification in the aortic arch. And these features are very important for our strategy. So, alteration of the left ejection fraction, abnormality of repolarization. So he underwent a Bayesian angiography, and you can see that there is a severe coronary disease with this stenosis on the first marginal, an important infiltration of the left main, very calcified. And on the cranial AP view, you can see that tight stenosis of this diagonal, infiltration of the LAD without any severe stenosis, and on the spider view, the stenosis on the ostium of the circ. The right coronary is also pathologic with multiple, and I apologize for the quality of the injection, but multiple severe stenosis from the proximal to the distal. And as there is a discrepancy between the Doppler ultrasound and the CT scan, we perform a selective angiography of the carotid to confirm this very tight stenosis at the ostium of the right carotid artery, quite long, not very calcified. For the key data for this patient is a frail patient of 80 years old, severe coronary artery disease with impaired left ejection fraction, tight asymptomatic stenosis on the right internal carotid, diffuse atheroma in the aortic arch, and aortic arch, which is a type 2 in an anatomic point of view.
So in this particular case, if we consider endarterectomy, so this patient is with high risk of ischemic coronary events. From trials comparing carotid stenting and endarterectomy, we know that endarterectomy is associated with higher rate of myocardial infarction and carotid stenting with higher rate of minor stroke in comparison to endarterectomy. So in this particular case, if we tailor our procedure based on clinical characteristics of this case, carotid stenting is really a viable option for carotid revascularization. So Marco, what would you suggest in this case?
Several points here I think worthy to discuss. The first is, was the carotid really asymptomatic? So there was a description of a brain lesion which was silent. Was the brain lesion in the territory of the carotid? So we can think that this may be a silent embolic event. On the other hand, we have to think that the patient has also atrial fibrillation. So this is also a cause of embolic events. In general, I think for asymptomatic patients, especially if they are octogenarian, we really want to have additional parameter of embolic risk, such as silent ischemic events, such as hemorrhagic plaque on MRI, such as progression of the plaque. So in general, we want to have an additional risk factor for stroke before treating the asymptomatic carotid.
A very good point. So once again, we have a high bleeding risk patient. So based on age and other criteria, this patient is again high bleeding risk. And again, we have a very strong evidence that in this case, Radial will offer additional benefit in terms of lower rate of bleeding and vascular complications.
And what about the particularity, the technical point, when you are moving from the radial, how to negotiate the angulation, the origin of the carotid? How are you doing this?
Yes, in our practice, we prefer Simmons 2 catheter. It's a radiological curve, but it is very, very elegant diagnostic catheter. We use it both for a left carotid and for right carotid. Some operators prefer a Simmons 2 for a left, but they go with Judkins right or internal mammary for a right common carotid artery cannulation. So it depends on a preference, but Simmons 2 is efficient diagnostic catheter in most cases.
And Sashko, maybe again, we are talking about bleeding complication. Obviously, there is the access issue, but we have even an octogenarian requiring anticoagulation. So what would be your antithrombotic regimen following carotid stenting for this patient?
Yeah, this patient can go on abbreviated 2 weeks to 1 month of dual antiplatelet with oral anticoagulation.
So triple therapy for 2 to 4 weeks?
Yes, because it's a larger vessel, so the risk of thrombotic complication is lower in comparison to coronary vessels. And we have to balance between the risk of ischemic thrombotic complications and bleeding risk. In this particular case, which is 83-year-olds, I will prefer to be more conservative on a shorter duration of antiplatelet regime, dual antiplatelet.
In the absence of high bleeding risk, what is your DAPT regimen?
DAPT at least for 1 month, at least 1 month. But for a low bleeding risk, 3 months is preferable. Yes. And very important patient subsets are those they are undergoing additional surgical procedure. Coronary surgical or valve replacement, and they have concomitant carotid. Now we have a very strong evidence that carotid stenting followed by surgery is probably one of the best hybrid approach in these cases in comparison to concomitant carotid surgery and heart surgery.
And heart surgery.
Yes.
Sasko, you perform coronary procedures, peripheral, you do everything through Radial. So in the same patient, I guess you come back several times during their lifetime. How do you take care of the hemostasis? Can you tell us a little bit more about that? Because I guess you hate right artery occlusion.
Oh, yes, yes, it's a very important point. That was the reason why we developed this ulnar access exit strategy in patients when radial is not available. So definitely a right radial is primary access. So we have never intended that ulnar will be primary access in most patients. So it is a secondary access, and we use it when radial is not available. So we have also some experience in more than 1,000 patients of ulnar access with occluded radial.
Yeah.
And also we have published our experience and no single-hand ischemia. But in all cases, there was significant collaterals predominantly from anterior intraossal artery.
I mean, you don't check for it anymore. I mean, it's for experience. You show that it's feasible, it's safe. Yes. Okay, it's a good message, I think, for the.
Yeah, and it's also particularly useful for emergency procedures like primary STEMI PCI. When right radial is not available, you cannot puncture, or it is remnant artery, then you can safely go through the same wrist through the ulnar artery.
And to go a little bit beyond, do you use now distal for your peripheral or not?
Just a few cases, but more and more we are using distal with a 5 French more hydrophilic sheets. Okay. Because, you know, and also distal we can use even with 7 French. You do not have to put whole length of your introducer, but you can safely go with, even with 7 French distal in a patient with properly sized radial artery.
Okay.
Maybe we can have a CT imaging so we can see that if we go from a radial, in this case, we are not aggressive to the aorta at all. I hope if it works, then we'll show how a right radial access is accessing the right common carotid artery for stenting of right internal carotid artery without touching aorta. So if you're not touching aorta, you're decreasing the risk of microembolizations. Yeah. Because even in carotid trials, there were significant proportions of patients that suffered from microembolization on non-target carotid. So let's say target was right common, right internal carotid, and there were microembolization on left side from catheter manipulations in aorta.
And Sasko, what is the crossover rate? I assume it's very small in your hands, but an intervention of the left carotid from the right radial.
Yeah, the most difficult for radial access is normal type 1 aortic arch with left carotid. But we manage this with high volume, and we developed this strategy of deep loop cannulation. So we use aortic valve for a hydrophilic wire advancement, and that's the way how you can manage these acute angulations. And you will have your loop in the ascendant aorta. Okay. Are there any questions for technical aspect of carotid stenting through radial access?
Maybe I have a question for before we have the images. So this patient clearly has coronary and carotid disease. So what is your strategy? Obviously here we have a carotid session, but in general, to which territory are you going first?
So it's an important question. We have to fix the carotid first. This is very important. Especially we can have, of course, a team decision for the CAD disease, but in the recommendation, if you have a multiple localization of the vascular disease, you have to fix the carotid first and then treat the coronary artery. Probably in this patient, we will do coronary angioplasty because it's very frail. There is a left ejection fraction, but it's 3 vessel disease, so we can discuss it. But for that purpose, carotid first.
There was, I think, very important question from the audience about any comparison between carotid stenting and carotid endarterectomy. And the experience from a question is that they use stent selection only for selective patients with contraindication to surgery. So there were very important trials published, randomized trials comparing carotid stenting and endarterectomy. There were large trials. Maybe the last one that was presented even 10 years ago, and now we have 10-year follow-ups, is a CREST trial. CREST trial showed no difference between endarterectomy and carotid stenting in terms of major adverse events. In arm of carotid stenting, there were higher rate of minor strokes in carotid stenting, and there were higher rate of myocardial infarction in carotid endarterectomy. So, and after 10 years, those results were published in a New England Journal of Medicine. There was no significant difference in the outcome of carotid stenting and endarterectomy. However, now we are living in the era of the second generation carotid stents, mesh stents, which have improved our results globally, and we have recently presented the results of a Road Saver trial. It is the largest pan-European trial on almost 2,000 patients where we have slightly above 1% of adverse events after 30 days. So it is perfectly in tune, even with the latest recommendations, European and American recommendations. So with this new technology, we are coming very close to results of even endarterectomy.
That's good. You can see.
Yes, may we have the live case?
Self-expandable stent. The common carotid is quite healthy, but there is not really a proximal landing zone, so probably we will have to treat from the common to the internal carotid.
Yes, I fully agree with you, Benjamin. Not too calcified, quite a long lesion, and an ostial lesion at the level of the internal carotid artery, and we will probably cover the external carotid by the stent.
And when we perform the intracerebral angiography, you can see that there is no defect of perfusion, and it's very important for the control at the end of the stenting to be sure that we don't have any loss of patency of intracerebral vessel.
Now you could see that we engage with the DSA, the external carotid artery with the terumo wire, and then we will advance the mammary catheter. We could exchange the terumo wire for a soft wire with a stronger support, a supracore 0.035 wire. We'll exchange the 0.035 wires with a stronger support wire, supracore, in the external carotid artery.
So it's an important message, Antoine. You put your guide wire in the external in order to go with the guiding catheter or the introducer.
Yes.
But not work on the internal carotid.
We will avoid to get through the lesion with the 0.035 wires.
So we will work today with 6-trench introducer, 90 centimeters length, destination from Terumo company. It's a MP shape, and we have 15 centimeters of hydrophilic coating to go very smoothly in the common carotid.
Now you could see that we will ascend and take the curve coming from the subclavian artery to the common carotid artery, and it goes very easily despite of the big loop of the artery. Now we could pull back the introducer, the dilator, and the wire.
When you perform carotid angioplasty, it's mandatory to use protection for embolization in the brain, distal or proximal. We use in our center distal protection with the ambush shield. And what is very important is to be sure that there is no air, no bubbles. And so the preparation of the filter is essential.
In this case, the patient is an asymptomatic patient. That's the reason why we choose distal protection device. In case of symptomatic patient, we will use the proximal protection device as a MoMA device. You have to follow the screen, and there is 4 different steps. The first one is to flush and to debug the bubbles from the filter, and then to load the filter. You put the saline, heparin saline in the box, and then you have a little syringe, and you will purge every bubbles into the device, into the filter. You could see, I think, on the screen that we flush and we release every bubbles from the filter. You take the torquer and you have to pull back all the device until the yellow marker arrived in front of the black distal port of the sheath, who will release the filter. Here you could see that we
enter very smoothly the internal carotid artery, and we advance in the same time the filter and the wire, and we will put the filter distally to the lesion just over there. Now we could open the filter. You have to release the red marker and then to pull back the white, we open the filter.
So Antoine, as you say, we have to put the filter as far as possible in the internal carotid before the entry of the carotid into the brain, of course. But it is very important because we will use self-expandable stent. And so far, if you put your filter too proximal, you can be in conflict with the shaft of the self-expandable stent.
Sometimes it's impossible to put a distal protection device when there is a lot of tortuosity and we are very close to the lesion, and we will prefer the use of proximal protection device. Benjamin, we have to choose the stent, and we will use the double layer mesh stent, the remote mesh stent. And in this case, we have the measurement with the QVA at the distal port of the lesion, above the lesion, 5.5 millimeter in terms of diameter. And if we consider the common carotid artery, we are very close to 6.5 millimeter. And that's the reason why we will choose a 7 millimeter in terms of diameter for the stent. And the length, the total length is more than 20, around 22 millimeter. And we will choose a 30 millimeter length Thermo mesh stent.
So as Antoine said, we will use the last generation of stent, self-expanding stent, road saver, double layer mesh stent. What does it mean, double layer? You have an external and internal layer of stent, which make the area of the strut from 375 micrometers to 500 at the maximum. And these features allow the protection of embolization of the lesion, and we will see on the angio how to place with the markers the double layer on your lesion. So you can appreciate the profile of the stent, self-expandable, it's compatible with the O14 guide wire, 5 French and 6 French compatible, 143 centimeters of length of the shaft. So Antoine, you cross the lesion. We will magnify to see the markers, 7 markers on the stent and the shaft. And this is very important for the precision of the double layer zone that we will put on the lesion.
Now you could see on the screen how to put the stent in the good position. Distal marker starts the simple layer. The second marker begins the dual layer, and then at the end of the stent, you have another third marker who will stop the double layer, and a fourth marker at the proximal port of the stent. We deliver every device, every stent in the lesion from the internal carotid to the common carotid artery.
So the key message here, Antoine, is to focus the double layer on the lesion, of course, and so you can see the distality marker, which is not the double layer. This is the distality of the stent. But we can see the second radio-opaque marker, which is the end of the double layer mesh. Yeah. So that is your repair when you want to put perfectly the layer on the lesion. So Antoine, of course, we have to optimize the stent. We will post-dilate with a 5 millimeters coronary balloon, 5 by 20. It's important to have a look on the hemodynamic and the OCG because we are inflating on the baroreceptor, and sometimes you can have some eye block or drop of blood pressure, and so we have to be focused on the ECG. And you can see the bradycardia induced by the post-dilatation of the stent, so it's something that you should be aware.
Now you could see the final angiogram. There is a very good result, Benjamin, till 10% residual stenosis, but there is no dissection above the stent, no dissection below, and a good apposition of the device at the level of the common carotid artery and at the level of the internal carotid artery. And I think that's enough. What we could discuss is to perform some OCT to see a position of the stent.
So you can appreciate the pullback of the OFDI terumo, and we will appreciate the double layer stent, as you can see on the screen, with a stent which is well opposed, well expanded, with no residual stenosis. And after we come back on the common carotid artery, and again, a stent which is well opposed to the vessel wall. When we go on the MSA, you can see that there is a minimal stent area of 14 millimeters square, given the good results of the angioplasty of this tight stenosis of the internal right carotid artery.
So maybe I can make a cut to keep in time for the discussion. I apologize for the technical issue. I think the key message is that the transradial approach changed our strategy in this patient, because engaging this type of right coronary stenosis by a transradial approach is very easy. And it's very safe because you avoid to navigate in the arch. We have seen in the presentation that the arch is full of atherosclerotic debris. And so going by the transradial approach changed our mind. The second point, I think, and Sasko said, it's an incredible double layer mesh stent to change the prognosis of angioplastic carotid. And actually, a carotid artery stenting is less than 1% of stroke or disable stroke or death. 1%, not 3%, which was the classical threshold, but now 1% with the filter, with a double layer, with a transradial approach, and I think it's a key message.
Yeah, in this particular case, also this new technology with double layer mesh stents provides sustained protection after procedure, not just during procedure, because 2/3 of embolic events are post-procedural. So with this technology, we have a lower risk and we have a sustained protection.
Comment, Marco?
No, I think it was a great case. Obviously, the discussion is proximal protection versus distal protection, radial and proximal protection. What is your opinion, Sasko?
Yes, radial is doable, but not in all cases, because radial MoMA is 8 French, but we also develop a strategy of sheetless MoMA insertion, which is lower than 8 French introducer. So it's pretty much like between 6 and 7 French, but sometimes angulations can be challenging, and I will encourage proximal protection practice after you become expert in carotid stenting with more than 100 cases with distal protection, then you can move to proximal.
There is a nice study who show that proximal protection and double layer mesh stent is the best association to decrease periprocedural events. But as Sasko says, the problem of the proximal protection is the French, 8 or 9 French. So in some small radial, you cannot use it.
So thank you, Benjamin, for this nice case. So to conclude what we have seen, it's a really nice case from Bruno Farah and Nicolas Desmonteil on the left main stenting via radial approach, and a simple way to perform it using this provisional stenting strategy. Then we had a very nice talk from Marco Roffi on the Master DIPT, and showing really the safety and efficacy on the reduction of dual antibiotic therapy to 1 month. And finally, this carotid stenting procedure with this double mesh device who give you, again, more safety and lower risk of embolization. The point, and this was interesting to see, even in what we can have in the cath lab, sometimes you can have a complication, a major problem, a major issue. And one of the major messages is to be relaxed, calm, quiet, and what we have done when we have this technical point with absolutely a crash of the video. And thank you for the technician to be, you did your best to come back to normal after 50 minutes of really difficult situation. Final question.
In case you have a thrombus in the radial artery, what's your approach? Do you use novel anticoagulants? You do something, you just leave it?
You want to go through that artery again with thrombus or just after the procedure?
For example, you make a PCI on a patient and 1 week after the PCI he came with a thrombus there. So what your strategy?
If patient is asymptomatic?
No, with pain.
With pain. So fortunately, it is extremely rare. Extremely rare. I cannot recall actually in maybe in last 5 or 7 years, single case like this. So it might be due to some embolization, because a risk of hand ischemia is not due to the occluded radial, it's due to embolization. Because you can see hand ischemia in ICU from prolonged radial monitoring, but you do not see embolization from catheterization. And that's the reason of success, a radial success in the previous 30 years. If it was an issue, we will not have this session after 30 years. There will be many hands lost, but it is not the case, fortunately.
So you don't take any...
No, you can. There was some evidence that enoxaparin or even some new anticoagulants, novel anticoagulants, are indicated in this case, but not strong clinical data, just anecdotal data.
Remember that
but you can give a try, I think, to do
radial occlusion is exceptional to have pain. Second, remember that the surgeon sometimes I take in the radial to use them for the graft, and so again the less is the best. Okay.
Thank you.
Another question? Thank you again, and sorry for the technical points. This is life. Thank you.